The name ankylosing spondylitis can be broken down. Ankylosing means stiffening, spondylo refers to the vertebra, and itis refers to inflammation. So ankylosing spondylitis is a chronic inflammatory disease that affects the vertebral joints and makes the spine really stiff, but can also cause inflammation in other parts of the body, like the eyes and blood vessels. Ankylosing spondylitis, also called Becker disease, is part of a group of diseases called seronegative spondyloarthropathies. Spondyloarthropathies are all autoimmune diseases that affect the joints, and they're seronegative, which refers to the fact that rheumatoid factor, which is an autoantibody, is not found in the blood. Alright, so in the healthy adult, the vertebral column is made up of 33 bones. From top to bottom, the first 7 bones are the cervical vertebrae. The next 12 are the thoracic vertebrae, and the last 5 are the lumbar vertebrae. Below that is a bone called the sacrum, which is attached to the pelvic bone on either side, called the ilium, and where they meet is the sacroiliac joint. Below the sacrum is a tiny bone called the coccyx, or tailbone. Now, there are 2 types of joints between the vertebrae. Between each of the vertebral bodies is an intervertebral disc, which is made of type 1 and type 2 collagen, and has 2 parts, the annulus fibrosus, an outer fibrous ring, and the nucleus pulposus, an inner jelly-like substance. This disc forms a joint between each vertebra, and it allows slight movement and acts as a shock absorber. In addition to the intervertebral discs, each vertebra has joints called facet joints, with the vertebra above and the vertebra below, one on each side. These joints are synovial, meaning they have a joint capsule and a small amount of synovial fluid in between. When you stretch your back, the capsule in these joints stretches too, and decreases the pressure in the joint space, which makes any gas suddenly come out of solution, making a cracking sound. These help guide and limit the range of motion in your spine. In ankylosing spondylitis, there's chronic inflammation of the intervertebral joints and the facet joints of the spine. The exact cause of inflammation is unclear, but it's thought to be due to an autoimmune process, which is when the immune system attacks its own tissue. In this case, the type 1 and type 2 collagen in the joints. But unlike many other autoimmune conditions, no autoantibody has been specifically linked to the disease. Normally, the cells of the immune system are ready to spot and destroy anything foreign that could cause the body harm. To help with this, most cells in the bodies have a set of proteins that combine together to form something called a major histocompatibility complex, or MHC, class 1 molecule, that sits on the surface of their cell membrane. Most individuals with ankylosing spondylitis have the gene HLA-B27, which is a gene that encodes for a specific type of MHC class 1 molecule. These specific proteins act kind of like a serving platter, and presents molecules from within the cell for the immune system to continually sample. A type of T lymphocyte, called a CD8 positive T cell, also known as a cytotoxic T cell, uses its T cell receptors to bind to the antigen presented by the MHC class 1 molecule. Normally, the molecule is just a sample from the cell, and the immune system recognizes it as harmless. And this is known as a self-antigen, and there's no response. But when these cells recognize a foreign molecule, they use cytokines to signal other immune cells to migrate to the joint capsule in the joint space that's under attack, cells like neutrophils. The neutrophils release cytokines like tumor necrosis factor alpha, or TNF alpha, and interleukin 1, or IL-1, which worsen the inflammation. Over time, the inflammation destroys the intervertebral joints, as well as the facet joints and the sacroiliac joints. And fibroblasts replace the destroyed joint with fibrin. Layers and layers of fibrin form a tough fibrous band around the outside of the joints, which limits their range of motion. Eventually, osteoblasts get activated, and a process called ossification will start, which is when the fibrous tissue turns to bone. In the beginning, small bony outgrowths will form at the joint edges, called syndesmophytes. This makes the part of the spine that's affected immobile, and sometimes that can be the entire spine. Other parts of the body can be affected too, like the eye, which can cause anterior uveitis. The aortic valve can also sometimes get inflamed and damaged, leading to aortic regurgitation. There can also be inflammation of tendons, like the Achilles tendon, called enthesitis. Ankylosing spondylitis is a systemic inflammatory disease, so it can cause symptoms like weight loss, fevers, and fatigue. If ankylosing spondylitis affects the sacroiliac joints, it typically causes buttock pain. And if it affects the cervical or thoracic region, it can cause neck or back pain and stiffness. Because the ribs and vertebrae are involved in breathing, stiffness can cause shortness of breath. Ankylosing spondylitis can be diagnosed using MRI, where there's typically erosion and narrowing of the joint spaces early on, and joint fusion later on. An X-ray and CT often show a bamboo spine, which is caused by the ossification of the annulus fibrosus on the outside of a straightened spine, giving it a hollow appearance. Genetic testing for HLA-B27 can be done to help confirm the diagnosis. Inflammation and pain from ankylosing spondylitis is usually treated with non-steroidal anti-inflammatory drugs, like ibuprofen. The pain can also be relieved by exercise or physical therapy. In more severe cases, disease-modifying anti-rheumatic drugs, or DMARDs, like sulfasalazine and methotrexate can be helpful. Newer therapies called biologics can also be useful, because they block the actions of cytokines like tumor necrosis factor alpha and the interleukins. Surgery can repair damaged hip and knee joints, but spinal surgery is typically considered risky and is rarely performed. Alright, as a quick recap, ankylosing spondylitis is an autoimmune process associated with the HLA-B27 gene, which attacks vertebral joints. In this process, collagen gets destroyed and replaced by fibrin, and ultimately ossification sets in, forming a bamboo spine on X-ray or CT scan. It can also affect the eyes, aorta, tendons, and lungs.
Gout is an acute inflammatory arthritis that occurs when monosodium urate crystals deposit in joints, soft tissue, and bones. This is typically associated with hyperuricemia due to either underexcretion or overproduction of uric acid. Risk factors include male sex, obesity, drinking too much alcohol, consuming certain foods like red meat and seafood, as well as dehydration, taking diuretics like thiazides, and increased cell turnover like in hemolysis or tumor lysis syndrome. The diagnosis of gout is made clinically and relies on the presence of classic symptoms, known risk factors, and lab findings. However, in some cases, when the diagnosis is not clear, joint aspiration may be needed. All right, if a patient presents with signs and symptoms suggestive of gout, you should first perform a focused history and physical examination. As well, order labs like serum urate, CBC, ESR, and CRP. Your patient may report rapid onset of redness, pain, and swelling in a joint, most commonly involving the big toe, but can involve other joints such as the knee. This is especially common after drinking alcohol or consuming purine-rich foods like red meat or seafood. Other risk factors include high fructose intake, diuretic use, obesity, history of diabetes, hypertension, and chronic kidney disease. Physical exam usually reveals redness, tenderness, and swelling in the involved joints, most often in the first metatarsophalangeal joint. You may also see subcutaneous nodules or tophi on the joints and pads of the digits. As far as labs go, the serum urate will often be elevated, greater than 6.8 milligrams per deciliter, but keep in mind that urate levels can be difficult to interpret during a gout flare. CBC typically reveals an elevated leukocyte count in inflammatory markers such as ESR and CRP. If you see this constellation of signs, symptoms, and lab findings, you can diagnose acute gout. Now let's look at a patient with a different but similar focused history and physical results. If your patient reports joint redness, pain, or swelling, but has no obvious risk factors for gout, physical exam reveals redness, tenderness, or swelling, but no tophi present, and if the serum urate and inflammatory markers are normal, then you should suspect arthritis. In this case, additional tests are needed to diagnose the type of arthritis. Specifically, perform a joint aspiration of the synovial fluid. If the synovial fluid contains no negatively birefringent needle-shaped crystals, consider an alternative diagnosis like pseudogout, septic arthritis, or Lyme arthropathy. However, if the microscopic synovial fluid shows negatively birefringent needle-shaped crystals with possible yellow cloudy fluid that contains white blood cells, you can diagnose acute gout. Here's a high-yield fact. Pseudogout is characterized by calcium pyrophosphate crystals, which are rhomboid-shaped and positively birefringent crystals, and can help differentiate gout from pseudogout. All right, now that you diagnosed acute gout, let's turn our attention to management. Within the first 24 hours of symptoms, begin pharmacological management and start your patient on anti-inflammatory medications for at least 7 to 10 days. Commonly used medications include NSAIDs like indomethacin or naproxen, but colchicine can also be prescribed. If your patient has impaired renal function or cannot tolerate NSAIDs or colchicine, give an oral or intra-articular glucocorticoid instead. Keep in mind that you should avoid glucocorticoids if you suspect a concurrent infection or if your patient has brittle diabetes. You should also review your patient's medication list, and if they are taking a diuretic, discontinue it or adjust the dose. Next, counsel your patient on non-pharmacologic treatment options like resting the affected joint and applying topical ice packs. Finally, be sure to encourage lifestyle modifications such as optimizing treatment of comorbid conditions like diabetes and hypertension, maintaining a healthy BMI, as well as minimizing alcohol use and consumption of purine-rich foods. Okay, now that you've treated your patient's gout flare, let's switch gears to long-term management. Be sure to assess your patient's response 2 to 4 weeks after the acute episode. Order an X-ray of the affected joint to assess for damage. If your patient has had less than 2 known gout flares per year, with no visible tophi on physical exam, as well as no joint damage seen on X-ray, continue lifestyle modifications to prevent future episodes. On the other hand, if your patient has had 2 or more gout per year, with 1 or more tophi seen on physical exam, as well as X-ray findings indicating joint damage, such as punched-out extra-articular erosions or soft tissue gouty tophi, start long-term medical therapy. Typically, long-term medical therapy involves the introduction of urate-lowering therapy, or ULT for short. However, paradoxically, ULT can initially trigger gout flares. This is because as soon as ULT is initiated, the urate crystals will start dissolving and get smaller. Some may get into another joint before being completely eliminated, causing a flare-up. To prevent this, begin gout flare prophylaxis. Your patient should take low-dose anti-inflammatories first for 2 to 4 weeks. Low-dose colchicine is commonly used as first-line prophylaxis, but NSAIDs or glucocorticoids can be used as well. Then begin urate-lowering therapy with ULTs such as xanthine oxidase inhibitors like allopurinol or febuxostat. Here's a clinical pearl to keep in mind. High serum urate levels not only lead to gout, but can often lead to urate kidney stones. In this case, treat urate nephrolithiasis with the same ULTs, but again, don't forget prophylactic medications for gout flares. Okay, so after your patient has been started on ULT, assess the response to treatment in 1 month. You can do this by checking a serum urate level. If the serum urate level is under 6 milligrams per deciliter, continue the gout flare prophylaxis for 6 more months, and then stop the anti-inflammatory medication if gout does not recur. Continue the ULT medication at the current dose, encourage your patient to continue lifestyle modifications, and follow your patient's long-term response to ULT by checking an annual serum urate level. On the flip side, if the serum urate is 6 milligrams per deciliter or more after 1 month of ULT, you should continue gout flare prophylaxis while making medication adjustments. This includes increasing the dose of or switching to a different xanthine oxidase inhibitor or adding a uricosuric agent. Encourage lifestyle modifications and recheck the serum urate level until you've reached a target of less than 6 milligrams per deciliter. Once your patient's urate has remained below target for 6 months, you can discontinue gout flare prophylaxis and continue to follow the serum urate level annually. All right, as a quick recap, if you suspect gout, look for risk factors like alcohol, purine-rich foods, or diuretic use, as well as red, painful, and swollen joints. You will also see elevated urate levels and inflammatory markers. On the other hand, if the presentation is unclear, perform joint aspiration and synovial fluid analysis. If there's negatively birefringent needle-shaped crystals, diagnose gout. Then start NSAIDs or colchicine. Alternative options include oral and intra-articular glucocorticoids. Additionally, counsel your patients on non-pharmacologic treatment options like resting, applying ice, and lifestyle modifications. Reassess in 2 to 4 weeks and order an X-ray. If your patient has less than 2 known episodes of gout per year, no tophi on exam, and no joint damage on X-ray, continue lifestyle modifications to prevent future episodes. On the other hand, if your patient has 2 or more episodes of gout per year, 1 or more tophi on exam, and joint damage on X-ray, start prophylactic anti-inflammatory medications for gout flares before you initiate urate-lowering therapy with xanthine oxidase inhibitors. After starting ULT, reassess in 1 month by checking a serum urate level. If less than 6 milligrams per deciliter, continue gout flare prophylaxis for 6 more months, and if there's no recurrence, stop the anti-inflammatory. Continue the current dose of ULT, lifestyle modifications, and recheck a urate level annually. On the flip side, if after 1 month of ULT, the serum urate is 6 milligrams per deciliter or greater, continue gout flare prophylaxis, adjust the ULT dose, or switch to a different ULT. Again, continue lifestyle modifications and recheck the urate until it's less than 6 milligrams per deciliter. Once the serum urate level remains below target for 6 months, discontinue gout flare prophylaxis and continue to follow the urate annually.
Sodium and forms monosodium urate crystals. These crystals can form as a result of increased consumption of purines, like from consuming purine-rich food like shellfish, anchovies, red meat, or organ meat. Also, though, they can result from increased production of purines. For example, high fructose corn syrup containing beverages could contribute to the formation of uric acid by increasing purine synthesis. Another way crystals could form is from decreased clearance of uric acid. which can result from dehydration from not drinking enough water or consumption of alcoholic beverages, both allowing uric acid to precipitate out. Regularly eating these kinds of foods can also lead to obesity and diabetes, both of which are risk factors for gout. Hyperuricemia can also develop as a result of chemotherapy or radiation treatment, since cells die at a faster than normal rate. Also, some individuals have a genetic predisposition to overproduction of uric acid, while others with chronic kidney disease may be unable to excrete the uric acid. Finally, there are some medications like thiazide diuretics and aspirin, which can also increase the levels of uric acid and therefore the risk of gout. Now, gout most often affects the first metatarsal joint of the foot, or the base of the big toe, and when it does, this condition is called podagra. Classically, in podagra, a person will wake up from sleep feeling like their big toe is on fire. Even the weight of the sheets can be painful. The pain is most severe in the hours immediately following the attack, and then generally lessens with time. But that discomfort and swelling can last for days or even weeks. Gout can also affect other joints as well, like those in the ankles, the knees, the wrists, and the elbows. This inflammation and local pain is ultimately caused by white blood cells, or leukocytes, which migrate to the site to help eliminate uric acid and release pro-inflammatory chemicals, including cytokines. Treatment of a gouty attack is typically focused on decreasing the pain and the swelling, most often with non-steroidal anti-inflammatory medications, or NSAIDs, like ibuprofen or naproxen sodium, but occasionally with corticosteroids as well. Colchicine, which has anti-inflammatory effects by inhibiting white blood cell migration, has also been used for a long time to treat gouty attacks. To treat the underlying cause of increased uric acid, though, it's important to modify the diet, doing things like staying well hydrated with water, as well as reducing or eliminating soda, alcohol, red meat, and seafood, and staying active to ward off obesity. There are also medications that help to decrease uric acid levels, which include xanthine oxidase inhibitors like allopurinol. Xanthine oxidase is an enzyme involved in the breakdown of purines to uric acid, so inhibiting this enzyme results in less uric acid production. Uricosuric medications, like probenecid, increase excretion of uric acid by the kidneys. Over time, repeated gouty attacks can develop into chronic gout, which is a type of arthritis with joint tissue destruction and permanent joint deformity. Chronic gout can eventually lead to permanent deposits of urate crystals, called tophi, which form along the bones just beneath the skin. Individuals with chronic gout are also at an increased risk for developing kidney stones made of uric acid, as well as urate nephropathy, which is when urate crystals deposit in the interstitium of the kidney. Okay, as a quick recap, gout is a type of inflammatory disease that typically affects the first metatarsal joint, which is the base of the big toe, where uric acid precipitates to form monosodium urate crystals, which deposit in the joint and lead to inflammation and pain. Thanks for watching. You can help support us by donating on Patreon or subscribing to our channel or telling your friends about us on social media. In psoriatic arthritis, arthritis means joint inflammation, and psoriatic refers to psoriasis, which is an autoimmune disease characterized by red scaly patches in the skin. So psoriatic arthritis is a type of joint inflammation that happens in individuals with psoriasis. Psoriatic arthritis is also one disease in a group of diseases called seronegative spondyloarthropathies. Spondyloarthropathies are autoimmune diseases that affect the joints, and they're seronegative, meaning that there aren't any specific autoantibodies linked to them. Normally, immune cells are ready to spot and destroy anything foreign that could cause the body harm. To help with this, most cells express the gene HLA-B27, which encodes a protein that forms a major histocompatibility complex, or MHC class I molecule that sits on the surface of the cell membrane. This MHC class I molecule acts like a serving platter, presenting molecules from within the cell for the immune system to sample. A CD8 positive T cell, also called a cytotoxic T cell, uses its T cell receptor to bind to the antigen presented by the MHC class I molecule. Normally, the antigen that's presented is from the cell, and the immune system recognizes it as a harmless self-antigen, which leads to no response. Now, many individuals with psoriatic arthritis have a specific version of the gene HLA-B27, which somehow leads to an autoimmune process. In these individuals, the immune system attacks self-antigens, specifically ones in the joints. Exactly what causes this is unclear, but it's clear that the gene itself is not enough to trigger psoriatic arthritis. Often, an environmental trigger like physical trauma or an infection seems to play a role as well. Ultimately, once the self-antigens are seen as foreign, T cells release cytokines, which increases inflammation, and stimulates other immune cells to release tumor necrosis factor, or TNF, as well as interleukin 12 and interleukin 23. This triggers keratinocytes and fibroblasts to proliferate, and leads to formation of a psoriatic plaque. In some individuals with psoriasis, T cells also go to the joints and trigger activation of osteoblasts and osteoclasts, leading to joint erosion and ossification, which can ultimately cause deformities. Psoriatic arthritis is chronic and progressive, which means that it typically worsens over time. The symptoms of psoriatic arthritis include pain, swelling, and stiffness in the affected joints. And since psoriatic arthritis is inflammatory, these joints are generally red and warm to the touch. Now, different joints can be affected, and there are 5 different types of psoriatic arthritis. In order from most to least common, there are oligoarticular, polyarticular or rheumatoid pattern, spondyloarthritis, distal interphalangeal predominant, and arthritis mutilans. The oligoarticular type is typically very mild, often asymmetric in terms of joint involvement, and usually involves fewer than 5 joints. The polyarticular type is also called rheumatoid pattern, because it resembles rheumatoid arthritis. It's usually symmetric and affects 5 or more joints, including the joints of the hands, wrists, feet, and ankles. The spondyloarthritic type is asymmetric and typically involves the spine and sacroiliac joint. It causes fusion of the vertebral bodies, and that leads to stiffness of the neck and the sacroiliac joint. The distal interphalangeal predominant type generally affects the joints nearest to the ends of the fingers and toes, causing sausage fingers or dactylitis, and nail abnormalities like ridging or pitting. Over time, some individuals with distal interphalangeal predominant type might develop severe bone erosions, as well as finger deformities, and this leads to the final type, which is arthritis mutilans. The extensive bone erosion at the fingers causes a telescopic digit appearance and results in a person having what's called the opera glass hand. Diagnosing psoriatic arthritis is challenging because it resembles rheumatoid arthritis. In addition, having psoriasis and arthritis doesn't always mean psoriatic arthritis, because there are other types of arthritis, like osteoarthritis, which can develop in individuals with psoriasis. Blood tests for the antibody rheumatoid factor, as well as anti-citrulline protein antibodies, can help, because they're commonly seen in rheumatoid arthritis, and are generally absent in psoriatic arthritis. Also, an X-ray can help show joint erosion, and show classic features like pencil and cup radiographic sign. Treatment of pain in mild cases of psoriatic arthritis includes non-steroidal anti-inflammatory drugs. In more severe cases, immunomodulatory drugs like sulfasalazine and methotrexate can be helpful. If NSAIDs or disease-modifying anti-rheumatic drugs fail, newer drugs called biological response modifiers can be used. These include the tumor necrosis factor inhibitors, like infliximab, etanercept, and adalimumab, which block the action of tumor necrosis factor alpha, as well as the interleukin 12, interleukin 23 inhibitor ustekinumab, which blocks the actions of the interleukins. Finally, surgery can be performed to repair damaged hip and knee joints, but spinal surgery is typically considered risky and is rarely performed. Alright, as a quick recap. Psoriatic arthritis is an autoimmune process, often associated with the HLA-B27 gene, which causes a T-cell mediated attack of the joints in people with psoriasis. There are 5 different types of psoriatic arthritis, which can be oligoarticular, polyarticular or rheumatoid pattern, spondyloarthritis, distal interphalangeal predominant, and arthritis mutilans. Treatment includes use of NSAIDs, sulfasalazine, and methotrexate, as well as newer biological response modifiers. Reactive arthritis, formerly known as Reiter syndrome, is inflammation of a joint which usually develops after an infection, and that infection is typically a sexually transmitted disease or gastroenteritis. Reactive arthritis is part of a group of diseases called seronegative spondyloarthropathies. Spondyloarthropathies are autoimmune, inflammatory joint diseases, and they're seronegative, which refers to the fact that an autoantibody called rheumatoid factor is absent from the blood. Normally, the immune cells are ready to spot and destroy anything foreign that could cause the body harm. To help with this, most cells in the bodies have a set of proteins that combine together to form something called a major histocompatibility complex, or MHC. And this is a molecule that sits on the surface of their cell membrane. There are 2 kinds of MHC molecules, class 1 and class 2. Class 1 molecules are found on most cells in the body, and they present molecules from within the cell for the immune system to continually sample. Normally, that molecule is just a sample from inside the cell, also known as a self-antigen. When immune cells pass by, they recognize this self-antigen as harmless, so there's no response. MHC class 2 molecules are found specifically on phagocytic cells, like macrophages, which destroy and digest foreign pathogens like bacteria. Once a macrophage destroys a bacterium, it presents a piece of that bacterium on its MHC class 2 receptor, and the macrophage then makes its way to the lymph node to find some T lymphocytes. A type of T lymphocyte called a CD4 positive T cell, also known as a helper T cell, uses its T cell receptors to bind to the foreign antigen presented by the MHC class 2 molecule. If the helper T cell binds strongly, the antigen's recognized as foreign, and the helper T cell switches on the corresponding B cell, so it can start producing a whole lot of antibodies. These antibodies bind to the specific pathogen, and typically prevent it from attacking the host cells, and at the same time they tag the pathogen for further destruction by other immune cells. Reactive arthritis can develop after a sexually transmitted infection, like chlamydia, or after gastroenteritis, caused by bacteria like Salmonella, Shigella, Yersinia, Campylobacter, and E. coli. These bacteria are all gram-negative, so they have molecules on their outer surface called lipopolysaccharides, sometimes shortened to LPS. These LPS molecules produce a strong immune response, so much so that their other name is endotoxin. Also, most individuals with reactive arthritis have the specific gene HLA-B27, which is one of many genes that has code to make MHC class 1 receptors. HLA-B27 is also associated with other inflammatory diseases, like psoriasis and ankylosing spondylitis. Exactly how reactive arthritis develops, though, is still unclear, but it probably has something to do with the way that lipopolysaccharides react with the MHC molecules on a cell surface. Now, because the immune system takes a little while to present foreign antigens and kick T cells into gear, reactive arthritis often starts 2 to 3 weeks after an initial infection. Tissues usually targeted by the immune system are tissues of the joint spaces, but occasionally the immune system also attacks tissues like the lining of the urethra and the conjunctiva. In fact, when all 3 of these tissues are affected, meaning the joint spaces, the urethra, and the conjunctivae, that causes a triad which associates arthritis, urethritis, and conjunctivitis. However, this triad is very uncommon, and usually only the joint spaces are affected. Other tissues that are sometimes involved include the cervix in women and the pericardium of the heart. Symptoms of reactive arthritis mainly involve pain and swelling of a single, large joint, like the knee. Less often, it can involve other joints like the ankles, hips, and small joints in the feet, or affect multiple joints. Other symptoms can include pain with urination, when urethritis is present, and redness of the eyes in the case of conjunctivitis, but these are less common. Finally, there can be cervicitis in women, which can cause pain with sexual intercourse, called dyspareunia, and pericarditis, which will cause chest pain and fevers. Rarely, reactive arthritis can cause keratoderma blennoragicum, which is a skin rash that can appear on the feet. Reactive arthritis is usually diagnosed based on the history of previous infection and the clinical exam. Also, testing for the HLA-B27 gene is often positive in those with reactive arthritis. Treatment focuses on identifying the infection that caused the problem, which usually means antibiotics. The non-steroidal anti-inflammatory drugs like ibuprofen can be used for joint inflammation. And if this doesn't work, then steroids can dampen the inflammation. Alright, as a quick recap, reactive arthritis is when an infection triggers joint inflammation somewhere else in the body, usually in a single large joint. Typically, the initial infection happens in the genitourinary or gastrointestinal system, and the gene HLA-B27 is present in most of these individuals. Diagnosis is made on history and examination, and treatment is with antibiotics and anti-inflammatory medication.
Rheumatoid arthritis is a chronic inflammatory disorder that gradually affects synovial joints, but can also cause extra-articular disease as well. Rheumatoid arthritis has been linked to HLA-DR1 and HLA-DR4. Each time there's a flare, there's an increase in synovial and immune cells, and over time, that results in a thick, swollen synovial membrane with granulation tissue, called a pannus. The pannus can damage cartilage and other soft tissues, and also erode bone. Typically, rheumatoid arthritis affects at least 3 joints, generally ones in the hands and feet. The disease tends to be symmetric, progressive, and over time, it causes joint deformities like crooked fingers. So, the typical articular manifestations in rheumatoid arthritis are pain, swelling, and loss of mobility in the affected joints, but doesn't usually cause redness or warmth because the inflammatory process is so gradual. Usually, there's morning stiffness that improves after 30 minutes of movement. The most frequent sites of involvement are the proximal interphalangeal joints and metacarpophalangeal joints of the hand, whereas the distal interphalangeal joints are rarely involved because there's very little synovium there. When these joints are affected, however, it typically causes reduced grip strength. In the feet, usually the metatarsophalangeal joints are affected, and it causes a person to bear more weight on the heels and hyperextend the toes. Other joints that can be involved are the wrists, elbows, shoulders, knees, and ankles. Hip involvement usually only happens later in the disease, and that can cause pain in the groin, thigh, or lower back. One very dangerous spot is the C1-C2 joint, which is the only synovial joint in the spine. When that's affected, it can cause neck pain, and if it's not managed properly, it can lead to spinal cord compression and tetraplegia. The system inflammation in rheumatoid arthritis results in cytokines that can cause extra-articular symptoms. For example, cytokines can trigger fever, fatigue, and a loss of appetite that can eventually lead to weight loss. Rheumatoid arthritis can lead to vasculitis, and specifically the formation of atheromatous plaques, which can lead to myocardial infarction and stroke. In fact, cardiovascular disease is the primary cause of mortality associated with rheumatoid arthritis. In skeletal muscle, cytokines cause muscle breakdown, and in the skin, they lead to the formation of rheumatoid nodules over bony prominences. Rheumatoid nodules are round collections of macrophages and lymphocytes that have a central area of necrosis. In the liver, lots of hepcidin is made, and that causes decreased iron absorption in the intestines, and allows iron to get trapped in the macrophages, leading to lower serum iron levels. In the lung, fibroblasts get activated, causing pulmonary fibrosis, and the pleural lining gets inflamed, leading to pleural effusions. Laboratory testing typically includes a complete blood count, which might show anemia of chronic inflammation, thrombocytosis, and a mild leukocytosis. In addition, an ESR and a CRP might be taken since they are markers of systemic inflammation. It's also important to test for autoantibodies like rheumatoid factor and anticyclic citrulline peptide antibodies, both of which are present in most individuals with rheumatoid arthritis. A minority of individuals may have antinuclear antibodies as well. Bilateral plane radiographs of the hands, wrists, and feet are also important as a baseline for monitoring disease progression. Over time, changes might include decreased bone density around affected joints, soft tissue swelling, narrowing of the joint space, and bone erosions. The diagnosis of rheumatoid arthritis can be made if the disease has gone on for at least 6 weeks, involves at least 3 joints, there's a positive rheumatoid factor or anti-citrulline peptide antibody, and an elevated CRP or ESR. In some cases, arthrocentesis may be done to evaluate the synovial fluid to make sure there's no evidence of crystals, like in gout or pseudogout, or signs of infection. In 2010, classification criteria were proposed, which established a 10-point scale, where getting at least 6 points out of 10 supported the diagnosis of rheumatoid arthritis. The first criterion gives points for either large joint or small joint involvement, whichever gets the higher point amount. Looking at large joints, if at least 2 large joints from among the shoulders, elbows, hips, knees, and ankles are affected, that gives 1 point. Looking at the small joints, if at least 1 to 3 from among the metacarpophalangeal joints, proximal interphalangeal joints, 2nd through 5th metatarsophalangeal joints, thumb interphalangeal joints, and wrists are affected, that gives 2 points. If 4 to 10 small joints are affected, that gives 3 points. And if more than 10 small joints are affected, that gives 5 points. The second criterion gives points based on the autoantibody levels. If there's a low positive rheumatoid factor, an anti-citrulline protein antibody, meaning above normal but below 3 times the upper limit of normal, that gives 2 points. If there's a high positive rheumatoid factor and anti-citrulline protein antibody, meaning more than 3 times the upper limit of normal, then that gives 3 points. The third criterion involves the ESR or CRP. If either are elevated, that gives 1 point. And finally, the fourth criterion involves the duration of arthritis, giving 1 point if it's lasted over 6 weeks. There's no cure for rheumatoid arthritis, but medications called disease-modifying anti-rheumatic drugs, or DMARDs, which are long-term medications, can minimize symptoms and prevent bone deformity. Most individuals with an acute rheumatoid arthritis flare are started on non-biological DMARDs like methotrexate. But some individuals, like pregnant people, can't take methotrexate, so they should get another non-biological DMARD, like hydroxychloroquine or sulfasalazine. Leflunomide is also another potential non-biological DMARD, but like methotrexate, it is also contraindicated during pregnancy due to its teratogenicity. And individuals with severe disease get biological DMARDs, also called biologics, all of which suppress some part of the immune system. For example, abatacept suppresses T cells and rituximab suppresses B cells. Some block chemokines, for example, adalimumab, etanercept, and infliximab all inhibit tumor necrosis factor or TNF. Anakinra blocks interleukin-1 and tocilizumab blocks interleukin-6. Individuals with rheumatoid arthritis should be seen at least every 3 months to monitor the response to therapy, and those who don't respond to initial DMARD therapy should get a combination of DMARDs such as methotrexate plus either hydroxychloroquine and sulfasalazine or a TNF inhibitor. In addition to long-term medications, Short-term medications like NSAIDs or even glucocorticoids like prednisone can be used to treat an acute flare. Finally, since individuals with rheumatoid arthritis have an increased cardiovascular risk, they should take preventative measures like exercise and smoking cessation, as well as routine use of low doses of aspirin and lipid control with statins. Alright, as a quick recap, rheumatoid arthritis causes progressive, symmetric destruction of at least 3 joints, especially in the hands and feet, over more than 6 weeks. But the main mortality comes from cardiovascular disease, especially myocardial infarction and stroke. Diagnosis is generally based on joint involvement, having an elevated rheumatoid factor and anticyclic citrulline peptide antibodies, and an elevated ESR and CRP. In addition, bilateral plane radiographs of the hands, wrists, and feet are generally obtained during the initial evaluation, primarily as a baseline for monitoring disease progression. The long-term management of rheumatoid arthritis is use of non-biological DMARDs. In addition, severe cases get biological DMARDs. Treatment of acute flares can be done with NSAIDs, while more severe flares might require short-term use of glucocorticoids, like prednisone. In addition, individuals should take preventative measures for cardiovascular disease, like exercise and smoking cessation, as well as routine use of low doses of aspirin and lipid control with statins.
In rheumatoid arthritis, arth refers to joints, itis means inflammation, and rheumatoid comes from rheumatism, which more broadly refers to a musculoskeletal illness. So rheumatoid arthritis is a chronic inflammatory disorder that mostly affects the joints, but can also involve other organ systems, like the skin and the lungs as well. Alright, so a healthy joint typically has 2 bones covered with articular cartilage at the ends. Articular cartilage is a type of connective tissue that acts like a protective cushion. It's a lubricated surface for bones to smoothly glide against. One type of joint, like the knee joint, is called a synovial joint. A synovial joint connects 2 bones with a fibrous joint capsule that is continuous with the periosteum, or the outer layer of both bones. The fibrous capsule is lined with a synovial membrane that has cells that produce synovial fluids and remove debris. The synovial fluid is normally a viscous fluid like a jelly part of a chicken egg, and it helps to lubricate the joint. To help serve these synovial cells, the synovial membrane also has blood vessels and lymphatics running through it. Together, the synovial membrane and the articular cartilage form the inner lining of the joint space. Rheumatoid arthritis is an autoimmune process that's typically triggered by an interaction between a genetic factor and the environment. For example, a person with a certain gene for an immune protein, like human leukocyte antigen or HLA-DR1 and HLA-DR4, might develop rheumatoid arthritis after getting exposed to something in the environment, like cigarette smoke, or a specific pathogen, like a bacteria that lives in the intestines. These environmental factors can cause modification of our own antigens, such as IgG antibodies or other proteins like type 2 collagen or vimentin. Type 2 collagen and vimentin can get modified through a process called citrullination. That's when the amino acid arginine found in these proteins is converted into another amino acid, citrulline. Meanwhile, due to the susceptibility genes, HLA-DR1 and HLA-DR4, immune cells are sometimes not clever enough, so they get confused by these changes and they no longer recognize these proteins as self-antigens. The antigens get picked up by antigen-presenting cells and get carried to the lymph nodes to activate CD4 T helper cells. T helper cells stimulate the nearby B cells to start proliferating and differentiate into plasma cells, which produce specific autoantibodies against these self-antigens. In rheumatoid arthritis, T helper cells and antibodies enter the circulation and reach the joints. Once there, T cells secrete cytokines like interferon gamma and interleukin 17 to recruit more inflammatory cells like macrophages into the joint space. Macrophages will also produce inflammatory cytokines like tumour necrosis factor or TNF-alpha, interleukin 1 and interleukin 6, which together with the T cell cytokines stimulate synovial cells to proliferate. The increase in synovial cells and immune cells creates a pannus, which is a thick, swollen synovial membrane with granulation or scar tissue made up of fibroblasts, myofibroblasts, and inflammatory cells. Over time, the pannus can damage the cartilage and other soft tissues, and also erode bone. Activated synovial cells also secrete proteases, which break down the proteins in the articular cartilage. And without the protective cartilage, the underlying bones are exposed and can directly rub against each other. In addition, inflammatory cytokines increase a protein on the surface of T cells known as RANK-L, or receptor activator of nuclear factor kappa B ligand. RANK-L allows T cells to bind RANK, a protein on the surface of osteoclasts, to get them to start breaking down bone. Meanwhile, antibodies also enter the joint space. One antibody is called rheumatoid factor, or RF, which is an IgM antibody that targets the constant Fc domain of altered IgG antibodies. Another antibody is anticyclic citrullonated peptide antibody, or CCP, which targets citrullonated proteins. When these antibodies bind to their targets, they form immune complexes which accumulate in the synovial fluid. There, they activate the complement system, a family of 9 small proteins that work in an enzymatic cascade to promote joint inflammation and injury. Finally, the chronic inflammation causes angiogenesis, or the formation of new blood vessels around the joint, which allows even more inflammatory cells to arrive. As the disease progresses, multiple joints on both sides of the body get inflamed and gradually destroyed. But these inflammatory cytokines don't just stay within the tight joint space. Instead, they escape through the bloodstream and reach multiple organ systems, causing extra-articular problems, meaning problems beyond the joint space. For example, interleukin 1 or 6 travel to the brain, where they act as pyrogens, inducing fever. In skeletal muscle, they promote protein breakdown, and in the skin, as well as many visceral organs, they lead to the formation of rheumatoid nodules, which are round-shaped collections of macrophages and lymphocytes with a central area of necrosis, or tissue death. Blood vessels can also be affected. Their walls get inflamed, resulting in various forms of vasculitis, and make them prone to developing atheromatous or fibrofatty plaques. In response to inflammatory cytokines, the liver also starts producing high amounts of hepcidin, a protein that decreases serum iron levels by inhibiting its absorption by the gut and trapping it into macrophages or liver cells. Meanwhile, within the lung interstitium, fibroblasts get activated and proliferate, causing fibrotic or scar tissue that makes it harder for the alveolar gas exchange. Also, the pleural cavities surrounding the lungs can get inflamed, and they fill up with fluid, known as pleural effusion, and this can sometimes mess with lung expansion. Rheumatoid arthritis typically involves multiple joints, usually 5 or more, symmetrically, meaning the same joint groups on both sides of the body, like both hands for instance. Commonly affected joints are the small joints, like the metacarpal phalangeal joints and proximal interphalangeal joints of the hand, and the metatarsophalangeal joints of the feet. As the disease worsens, it can start to affect large joints, like the shoulders, elbows, knees, and ankles. During flares, or sudden worsening of the disease, the affected joints get extremely swollen, warm, red, and painful. Over time, they become stiff, especially in the morning or after being inactive for a prolonged period of time. People with rheumatoid arthritis may develop specific deformities, usually of the metacarpal phalangeal joints of the hand, such as ulnar deviation of the fingers. Deformities are also common in the interphalangeal joints, such as the so-called boutonniere or buttonhole deformity. This occurs when the extensor tendon in the back of the finger splits and the head of the proximal phalanges pokes through, like a button through a buttonhole, causing flexion of the proximal interphalangeal joint and hyperextension of the distal interphalangeal joint. Another finger deformity is the swan neck deformity, which is the opposite. So there's hyperextension of the proximal interphalangeal joint and flexion of the distal interphalangeal joint. Now, in the knee joint, a one-way valve can form, with fluid from the swollen knee filling the semimembranous bursa. When that happens, the synovial sac can get so swollen that it bulges posteriorly into the popliteal fossa, creating a synovial fluid-filled cyst, called a Baker or popliteal cyst. Extra-articular manifestations include non-specific symptoms of inflammation, such as fever, low appetite, malaise, or muscle weakness. Organ-specific manifestations include rheumatoid nodules, or firm bumps of tissue, and these are most commonly found in the skin around pressure points, such as the elbows. More rarely, they can be found in the lungs, the heart, or the sclera of the eye. There's also an increased risk of atherosclerosis and therefore heart attack or stroke. There's also anemia, interstitial lung fibrosis, and pleural effusions, which can present as progressive shortness of breath. One particularly serious condition that's associated with rheumatoid arthritis is Felty syndrome, which is a triad of rheumatoid arthritis, splenomegaly, and granulocytopenia, and it can lead to life-threatening infections. Diagnosis of rheumatoid arthritis usually involves confirmatory blood tests, like looking for the presence of rheumatoid factor and anti-citrullinated peptide antibody. Additionally, imaging studies, such as X-ray, usually reveal decreased bone density around the affected joints, soft tissue swelling, narrowing of the joint space, and bony erosions. The long-term management of rheumatoid arthritis is the use of disease-modifying anti-rheumatic medications, like methotrexate, hydroxychloroquine, and sulfasalazine, which can help to suppress the inflammation. In addition, there are a variety of medications called biologic response modifiers, or biologics. Some biologics, such as abatacept, work by suppressing the activity of T cells, or others, such as rituximab, suppress B cells. There are also biologics such as adalimumab, etanercept, and infliximab that block various chemokines, like tumor necrosis factor. Anakinra blocks interleukin-1, and tocilizumab blocks interleukin-6. Treatment of acute flares can be done with anti-inflammatory medications, like NSAIDs, as well as short-term use of glucocorticoids. Alright, so as a quick recap, rheumatoid arthritis is a systemic inflammatory disorder of autoimmune origin that's primarily characterized by progressive symmetric joint destruction, especially in the wrists and fingers, but may also affect other joints and many organs, such as the skin, heart, blood vessels, and lungs. It's marked by elevated rheumatoid factor and anticyclic citrullinated peptide antibodies.
Septic arthritis refers to joint inflammation that occurs when a pathogen invades the joint space. Once within the synovial cavity, pathogens trigger the immune system and stimulate the production of cytokines that can eventually result in joint damage. Now, there are various ways for a bacteria to get into a joint. For example, it can spread directly from an infection in the adjacent bone, such as osteomyelitis. It can also reach the joint through hematogenous spread from a distant infectious site in the body, or by direct inoculation, which can occur as a complication of orthopedic surgery. Septic arthritis is usually monoarticular, affecting one large joint, and the diagnosis typically relies on synovial fluid aspiration and analysis. Now, if you have a patient presenting with signs and symptoms of septic arthritis, you should first perform an ABCDE assessment to determine if your patient is unstable or stable. If the patient is unstable, stabilize their airway, breathing, and circulation. Next, obtain IV access, start IV fluids, and begin continuous vital sign monitoring, including blood pressure, heart rate, and oxygen saturation. Provide supplemental oxygen if needed, and don't forget to start broad-spectrum IV antibiotics. Okay, now let's go back to the ABCDE assessment and look at stable patients. First, let's start by taking a focused history and physical exam. Your patient will typically report monoarticular joint pain and swelling, commonly of the hips, knees, shoulders, or ankles. These joints are the most vulnerable to infection because they have a richer blood supply than small joints, and that enables pathogens to more easily reach the larger joints. Your patient might also report systemic symptoms such as fever, malaise, and decreased appetite. They may also have a history of risk factors, including overlying skin infection or ulceration, history of a prosthetic joint or recent joint surgery, immunosuppression, IV drug use, and smoking. Additionally, a physical exam may reveal an ill-appearing patient with a joint effusion or erythema and warmth of the skin overlying the affected joint. Also, local edema and pain typically results in a limited range of motion of the affected joint. At this point, you should suspect septic arthritis. So the next step is to assess whether the affected joint is a native or prosthetic joint. Let's say your patient has their native joint. Your next step is to do an arthrocentesis and order synovial fluid analysis, including gram stain and cultures, cell count with differential, and crystal analysis. While awaiting results, you should start empiric antibiotics. Now, here's a high-yield fact to keep in mind. Septic arthritis is most commonly caused by bacteria, and based on the pathogen that's causing it, septic arthritis can be further subdivided into gonococcal and non-gonococcal. Gonococcal arthritis is caused by Neisseria gonorrhea, which typically spreads hematogenously from the initial infection of the urethra, cervix, or even pharynx. Remember that this is more common in sexually active adolescents and young adults. On the other hand, non-gonococcal arthritis is caused by all other pathogens, especially Staphylococcus aureus, but also Streptococcus species, as well as Mycobacterium tuberculosis and Borrelia species. Another less common cause of septic arthritis in sexually active individuals is chlamydia. Okay, now that you've obtained synovial fluid and started empiric antibiotics, you should next assess the results of the synovial fluid. If the gram staining cultures are negative and the synovial fluid is clear and yellow with a white blood cell count less than 2,000 and is negative for crystals, you should consider non-inflammatory arthritis, such as osteoarthritis. On the other hand, if gram stain and culture are negative and the synovial fluid is cloudy and yellow, containing a cell count up to 50,000, and with or without positive crystals, you should think of inflammatory arthritis. In this case, consider either gout or calcium pyrophosphate deposition disease, which are associated with positive synovial fluid crystals, or rheumatoid arthritis, in which there are no crystals present. Finally, if the gram stain and cultures are positive, and the fluid is cloudy and purulent with a cell count over 50,000, and with or most often without positive crystals, you can diagnose septic arthritis. Keep in mind that patients with a history of gout can develop septic arthritis in the same joint, and in those cases, there will be crystals in the synovial fluid. Here's a clinical pearl. To definitively diagnose septic arthritis, you will rely on synovial fluid analysis. Sometimes, additional supportive analyses, such as labs, primarily CBC, ESR, and CRP, as well as imaging like X-ray, ultrasound, and MRI, are also ordered. These additional diagnostic methods can help you rule out other conditions, while at the same time confirming the diagnosis of septic arthritis. Lab findings will typically reveal leukocytosis, as well as elevated ESR and CRP, which are highly suggestive of ongoing infection. Additionally, an X-ray may show narrowing of the joint space due to cartilage destruction, surrounding soft tissue swelling, and subchondral bony destruction. Ultrasound can also be used to look for a joint effusion in a joint with clinical suspicion for septic arthritis, and potentially help guide joint aspiration. Finally, MRI can be used to look more closely for joint damage, bone marrow edema, and further characterize any joint effusion. This is crucial to rule out possible osteomyelitis. Okay, now that you are confident in your diagnosis, you can tailor antibiotics based on synovial culture results. You should also obtain urgent surgical consultation for further drainage and debridement, as untreated infections can result in loss of function of the joint. Now, let's go all the way back to our affected joint and discuss what we do if the patient has a prosthetic joint. In these cases, you'll want to get an X-ray to help screen the prosthetic for loosening or fracture, perform an arthrocentesis for synovial fluid analysis, and get labs like CRP, ESR, and a blood culture if the patient has a fever. Okay, now an X-ray may demonstrate an abnormal lucency where the prosthetic meets the bone, a change in the position of the prosthetic, as well as a periosteal reaction. The synovial fluid analysis will be similar to the results for native joint septic arthritis. The gram stain and culture might be positive, but keep in mind that prosthetic joints are more susceptible to unusual organisms, like fungi, and so culture results may take weeks or may return negative. In addition, the fluid will be cloudy and purulent, the cell count will be greater than 50,000, and the synovial fluid is typically negative for crystals. These findings are consistent with a prosthetic joint infection. Here's a clinical pearl. Depending on how sick the patient is, sometimes surgical management, including debridement, is performed instead of the arthrocentesis, even before the diagnosis is known. This happens in both native and prosthetic joint infections. In these cases, surgical findings of purulent material around the joint can help make the diagnosis as well, both visually and with fluid analysis. All right, after diagnosing a prosthetic joint infection, your next step is to start empiric antibiotics and tailor them if culture results indicate doing so. Unlike with native joint infections, it's preferred to delay starting antibiotics until obtaining synovial fluid culture whenever possible. You should also obtain an urgent surgical consultation for further drainage and debridement if not already done, as untreated prosthetic joint infections can result in loss of the prosthetic and even amputation of the limb. All right, as a quick recap, septic arthritis occurs when a pathogen invades the joint space and causes inflammation. Your patient will primarily report monoarticular joint pain and swelling. Physical exam findings include joint effusion, erythema, warmth, and limited range of motion. Native joint infections are characterized by synovial fluid analysis showing positive gram staining cultures, cloudy purulent fluid, cell count over 50,000, and usually negative crystals. So treat by tailoring antibiotics and consulting surgery. On the flip side, prosthetic joint infections often show an abnormal X-ray, while synovial fluid analysis shows positive gram staining cultures, cloudy purulent fluid, cell count over 50,000, and negative crystals. So start empiric antibiotics and consult surgery.
Septic arthritis, which is also called infectious arthritis, refers to any joint inflammation caused by a microbe, and usually it results from a bacterial infection of the joint. All types of joints, fibrous, cartilaginous, and synovial joints, can get infected, so let's just use the synovial type as an example. A synovial joint consists of a joint capsule which has an outer fibrous layer and an inner synovial membrane filled with synovial fluid. The synovial fluid is a clear, viscous fluid that looks like the white of an egg, and it helps lubricate the joint and absorb shock. The synovial membrane has blood vessels that supply the joint with nutrients and oxygen. The tips of the bones that come together to form the joints are covered by an articular cartilage, which is a slippery smooth layer of cartilage that also absorbs shock and reduces friction during movement. Now, there are various ways that a bacterium can get into your joint. First, it can be from a pre-existing infection in adjacent tissue, usually the bone, from where a bacterial infection can spread to the articulating part of the bone and then makes its way right into the joint. It can also develop from a hematogenous spread, which is where the bacteria is somewhere else in the body, like the lungs, and then travels through the bloodstream and gets into the joint. So, let's say a child falls on some dirty planks of wood and a nail pierces through their knee, infecting the synovial membrane with bacteria. That bacteria could either come from the nail and be living in the environment, like Clostridium tetani, which causes tetanus, or it could be bacteria that lives on the skin surface and gets shoved deep into the joint at the moment that the skin is pierced, like Staphylococcus aureus. Once bacteria get into the synovial cavity, they start destroying the articular cartilage with their toxins. One example of a toxin is a chondrocyte protease, which is a powerful enzyme that's capable of digesting the collagen in the articular cartilage. Also, bacteria present with pathogen-associated molecular patterns, or PAMPs, which is a group of bacterial surface antigens that are recognized by your innate immune system as foreign and result in the initiation of an immune response. Macrophages can spot bacteria by their PAMPs. They phagocytose them and at the same time release cytokines such as interleukin-1 and tumor necrosis factor alpha. These are signaling chemicals that recruit more immune cells to the site of infection. Also, these PAMPs get recognized by mast cells and they release histamine, which causes vasodilation and increases the vascular permeability. The final result is that more blood comes into the area, creating an inflammatory response, which makes the joint look red, swollen, and warm. As more fluids leak out of the capillaries and accumulate in the joint space, there's an increase in the intra-articular pressure, compressing and interrupting blood vessels supplying the joint. Eventually, this leads to necrosis of the affected bones and cartilage, leading to joint destruction. People with septic arthritis develop joint pain, impaired range of motion, and fever. But symptoms may differ according to the underlying pathogen. Gonococcal arthritis, which is caused by Neisseria gonorrhoeae, usually affects sexually active adolescents. The bacteria typically spreads hematogenously and spreads from an initial infection of the cervix, urethra, or pharynx. Neisseria gonorrhoeae affects multiple joints and also causes multiple skin lesions and tenosynovitis, which is inflammation of the muscle tendons. Now, the majority of septic arthritis is not due to Neisseria gonorrhoeae, and it's called non-gonococcal arthritis. Non-gonococcal arthritis includes all of the other pathogens, but most often a single joint will be affected, typically a knee. Non-gonococcal arthritis is most often caused by Staphylococcus aureus, which can completely destroy the joint within days unless it's treated. Other bacterial causes include multiple Streptococcus species, as well as Mycobacterium tuberculosis and Borrelia species, which is the cause of Lyme disease. Diagnosis of septic arthritis starts with obtaining synovial fluid from the joint, which is done by doing a joint aspiration, where a needle is placed into the joint and fluid is aspirated or drawn out. That synovial fluid can be sent out for analysis, and typically there's a high white blood cell count, positive gram stain, or a positive culture, which identifies the exact cause. In addition, imaging in the form of an X-ray, ultrasound, CT scan, or MRI can also be very useful in demonstrating bone erosion and joint effusions, especially for hip and sacroiliac joints, where synovial fluid aspiration is difficult. Treatment of septic arthritis typically starts with antibiotic therapy and pain medication. In addition, it may require joint aspiration and washout, which can be done by a needle, a process called arthrocentesis. Alternatively, it can be done by opening the joint, a surgical operation known as arthrotomy. Alright, as a quick recap. In septic arthritis, there's joint inflammation, which can be caused by various bacterial infections, which spread contiguously or hematogenously. The minority of the time, it's caused by Neisseria gonorrhoeae, and it's called gonococcal arthritis. But the majority of the time, it's caused by Staphylococcus aureus or some other bacteria, and it's called non-gonococcal arthritis. Diagnosis requires getting joint aspiration and imaging, and treatment includes antibiotics and surgical management.
Osteoarthritis is a degenerative disease of the joints, characterized by mechanical wear and tear injury to articular cartilage, resulting in bony and synovial damage. This chronic inflammatory process is mediated by cytokines such as interleukin-1 and tumor necrosis factor alpha, and can affect any joint, but it most commonly affects the knees, hips, hands, and feet. Important risk factors for osteoarthritis include age, being biologically female, obesity, and joint injury. Now, in most cases, osteoarthritis is a clinical diagnosis, but sometimes imaging with X-ray might be needed if the diagnosis is not clear. Now, if your patient presents with signs and symptoms suggestive of osteoarthritis, first you should perform a focused history and physical examination. The patient will typically have a history of joint pain that began in an isolated joint, such as the knee, hand, like the interphalangeal joints, wrist, or feet, like the metatarsophalangeal joints. Also, your patient may describe joint pain that is worse with activity and have limited joint range of motion. They may also have minimal morning stiffness that typically lasts less than 30 minutes before improving. Now, here's a clinical pearl to keep in mind. If your patient has morning stiffness that lasts longer than 30 minutes, then consider inflammatory arthritis, such as rheumatoid arthritis instead. Another way to distinguish between the two is by the pattern of affected joints. Rheumatoid arthritis tends to be symmetric, meaning that joints on both sides of the body are equally affected, whereas patients with osteoarthritis are more likely to have asymmetric joint involvement. On the other hand, the physical exam may reveal tenderness along the joint line and crepitus, which is a grating sound or sensation when the joint moves. Your patient may also have pain with range of motion testing of the joint, a limited range of motion, as well as bony enlargement of the interphalangeal joints. Bony enlargement at the distal interphalangeal, or DIP joints, is called Heberden nodes, where enlargement at the proximal interphalangeal, PIP joints, is called Bouchard nodes. If the history and physical exam findings are consistent with osteoarthritis, then no further testing is needed and you can diagnose osteoarthritis. But if the diagnosis is not clear, you should order an X-ray of the affected joint. If the X-ray findings are not consistent with osteoarthritis, you should consider an alternative diagnosis. But if the X-ray shows joint space narrowing, osteophytes, and subchondral sclerosis, you can diagnose the patient with osteoarthritis. Here's a clinical pearl to keep in mind. X-ray findings don't always correlate with symptoms in patients with osteoarthritis. For example, the X-ray could show severe joint damage, but the patient may only have mild symptoms. Now, once you have diagnosed osteoarthritis, the next step is to determine which joints are affected. The treatment options differ based on which joints are involved. All right, let's say your patient has osteoarthritis of the knee or hip. The first step is to begin non-pharmacologic management. First, encourage exercise and physical activity to reduce pain by increasing muscle strength and improving the range of motion in the affected joints. Second, recommend weight loss, especially if your patient has a BMI greater than 25. Weight loss relieves stress on weight-bearing joints, meaning many patients see significant pain relief and improvement in mobility. Third, recommend Tai Chi to your patients, which is a traditional Chinese mind-body practice that can improve strength and balance and help relieve pain. Finally, patients with knee or hip osteoarthritis have difficulty walking, so they might benefit from using assistive devices such as a cane or knee brace, as well as foot orthoses. After trying one or more non-pharmacologic therapies, you should assess your patient's response. If your patient has an adequate response, meaning they have significant pain relief and improved function, then continue non-pharmacologic management. However, if there is an inadequate response, continue the current therapy and consider starting pharmacologic management. If your patient has osteoarthritis of the knee, prescribe a topical NSAID for pain reduction. Topical NSAIDs have similar efficacy to oral NSAIDs, but don't carry the same risk of side effects. Keep in mind, topical NSAIDs are not effective in people with hip osteoarthritis due to the location and depth of the joint. So in this case, your patient can try oral NSAIDs, But remember, this has a higher risk of adverse effects in patients with chronic kidney disease or cardiovascular disease. In addition, be cautious in using NSAIDs in patients with peptic ulcer disease or a history of GI bleeding, as NSAIDs can worsen these conditions. Finally, another option is oral duloxetine, which is a serotonin reuptake inhibitor. Okay, so after a trial of first-line pharmacologic management, you should again assess the patient's response. If your patient has an adequate response, continue the current management. On the other hand, if there is an inadequate response, consider starting second-line pharmacologic management with intra-articular glucocorticoids or hyaluronic acid, which are injected directly into the affected joints. Intra-articular glucocorticoids address inflammation and can temporarily reduce pain and improve joint function. But they're being used less frequently as newer evidence shows they may negatively affect the joint hyaline cartilage. In contrast, intra-articular hyaluronic acid acts as a cushion to lubricate the joint. Here's a clinical pearl to keep in mind. Glucocorticoids can temporarily increase blood glucose levels, so advise your diabetic patients to monitor their blood glucose levels carefully for several days after receiving intra-articular glucocorticoids. Next, give your patient some time and again assess their response to treatment. If the patient has an adequate response, continue current management. However, if their joint function still doesn't improve, refer the patient for surgical consultation for possible joint replacement. Okay, now that we've reviewed what to do for knees and hips, let's switch our focus to osteoarthritis of the hands. If your patient presents with osteoarthritis of the hand, your first step is to begin non-pharmacologic management. Just like those with osteoarthritis in the knees and hips, patients with hand osteoarthritis benefit from exercise that strengthens the muscles and improves joint mobility. Consider referring the patient to an occupational therapist to supervise their exercise program. Additionally, if your patient has osteoarthritis of the first carpometacarpal joint or base of the thumb, try a hand orthotic to help stabilize the joint and improve grip strength. Again, don't forget to assess the patient's response. If the patient has an adequate response, then continue the current management. However, if there is an inadequate response, then continue the current therapy and start pharmacologic management with a topical NSAID, oral NSAID, or oral duloxetine. Again, be mindful of possible contraindications to NSAID use, such as chronic kidney disease, cardiovascular disease, peptic ulcer disease, or history of GI bleeding. All right, as a quick recap, osteoarthritis is a degenerative disease of the joints characterized by mechanical wear and tear injury to articular cartilage, resulting in bony and synovial damage. Diagnosis is made clinically based on joint pain with stiffness lasting less than 30 minutes. Physical exam typically reveals tenderness along the joint line, crepitus, limited range of joint motion, and bony enlargement. This should be enough to diagnose osteoarthritis, but if you're still not sure, order an X-ray to confirm the diagnosis. You'll then want to start treatment with non-pharmacologic management, including exercises and supportive devices. If the patient is not responding, consider pharmacological therapy. For larger joints, if none of these interventions work, you should then consider surgical consultation for joint replacement.
Osteo means bone, and arth refers to arthron, which means joint, and itis means inflammation. So osteoarthritis is a disease involving inflammation of the bone and joint cartilage. It was once thought that the itis part of osteoarthritis was a misnomer, and that inflammation didn't play a role in its development, and that it was mostly a degenerative disease resulting from simple wear and tear. Nowadays, it's thought that inflammation does indeed play an important role in the development of osteoarthritis. Alright, so a healthy joint consists of two bones, each with its own layer of articular cartilage, which is a type of connective tissue that allows the two bones to glide against each other, essentially without friction. With osteoarthritis, we're really talking about one particular kind of joint, which is a synovial joint. Along with articular cartilage, another important component of synovial joints, and where they get their name from, is the synovium, which, along with the surface of articular cartilage, forms the inner lining of the joint space. The synovium is composed of loose connective tissue, blood vessels, lymphatic vessels, and on the surface, type A cells that clear cellular debris, and type B cells that produce components of the synovial fluid, which helps lubricate the two articular surfaces. One of the main issues in osteoarthritis is the progressive loss of this articular cartilage, which means there's not much separating the two bones anymore, which adds a significant amount of friction between them, which then generates inflammation and triggers pain through the nerve endings in this joint space. Maintaining healthy articular cartilage is the chondrocyte's job, a specialized cell responsible for maintaining everything cartilage related. The chondrocytes produce and are embedded within a strong gel or extracellular matrix, which contains type 2 collagen, a protein that provides structural support, as well as proteoglycans, which are aggregates of protein and sugar molecules like hyaluronic acid, chondroitin sulfate, and keratin sulfate. All of these extracellular components give the cartilage elasticity and high tensile strength, which help weight-bearing joints distribute weight such that the underlying bone absorbs the shock and the weight. And these are joints like the knees, the hips, and the lower lumbar spine. Okay, so chondrocytes are important for the articular cartilage. Got it. That makes sense. In healthy people, chondrocytes maintain a delicate balance between breaking down old cartilage, called catabolic activity, and producing new cartilage, called anabolic activity, through the use of both degradative enzymes and synthetic enzymes. When something causes an increased expression of degradative enzymes, then the balance tips toward a net loss of cartilage via loss of proteoglycans and collagen. What sort of something, though, can cause an increased expression of degradative enzymes? Well, that's the million-dollar question, right? And the answer isn't super straightforward. The biggest risk factor for osteoarthritis seems to be age, and often the cartilage degrades over long periods of time, which makes it really hard to pinpoint one single culprit. As I mentioned earlier, inflammation also seems to be involved, and there are a number of pro-inflammatory cytokines like interleukin-1, interleukin-6, and tumor necrosis factor, among others, that seem to play a role. Some of these are more involved in breaking down cartilage through proteolysis, meaning increased catabolism, whereas others are more involved in blocking the formation of new cartilage, meaning decreased anabolism. Also, joint injury, which brings with it a lot of inflammation, seems to be a major risk factor for osteoarthritis, as well as mechanical stress and obesity. Other risk factors include neurologic disorders, genetic factors, and even certain medications, suggesting that there are other mechanisms at play as well. Whatever the initial cause of articular cartilage damage is, it gets the chondrocytes to start trying to repair the cartilage. They initially start making less of the proteoglycans and more type 2 collagen, but soon switch over to making a different collagen type, type 1 collagen. Unfortunately, type 1 collagen doesn't interact with the proteoglycans in the same way, and there's this overall decrease in elasticity in the cartilage matrix, allowing it to break down. Eventually, though, over the course of years, chondrocytes aren't able to keep up, and they become exhausted, and they can undergo apoptosis, or programmed cell death. The cartilage gets softer, weaker, and continues to lose elasticity, and it starts to flake off into the synovial space, called joint mice. As type A cells in the synovium attempt to remove the debris, immune cells like lymphocytes and macrophages are recruited into the synovial membrane, which produces pro-inflammatory cytokines that ultimately cause inflammation of the synovium as well, called synovitis. Also, fibrillations form, essentially these cracks or clefts on what used to be smooth articular surface. The cartilage continues to erode away until the bone's exposed, allowing it to rub with the other bone, which causes bone eburnation, making it look like polished ivory. Finally, on the edges, bone grows outward, called osteophytes, which makes the joints look wider, something that's most obvious when it's seen in the distal and proximal interphalangeal joints, or the finger joints. called Heberden nodes in the distal joints and Bouchard nodes in the proximal joints. Osteoarthritis is really common, and nearly everyone knows someone that suffers from it. People with osteoarthritis often feel stiffness in the morning, which usually lasts less than an hour, but comes back at the end of the day. This is an important difference between rheumatoid arthritis, an inflammatory disease that also affects the joints. With rheumatoid arthritis, morning stiffness usually lasts longer than an hour. The pain in osteoarthritis is usually a sharp ache or burning sensation, which also gets worse with prolonged activity. But usually the joints don't swell, whereas rheumatoid arthritis typically involves painful swelling. Finally, management or treatment of osteoarthritis can involve non-pharmacological approaches, like losing weight or moderate exercise, as well as physical therapy. This can be especially important for large weight-bearing joints like the hips and the knees. Pharmacological treatments focus on reducing pain and inflammation. If neither of these approaches are successful, though, sometimes patients might benefit from injections of hyaluronic acid into the joint, or they might need surgery to replace the affected joint. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media.